afternoon. I apologize for the tardiness on this here. I had a couple of things pop up in the past couple of weeks that have kind of precluded me from being able to get this taken care of, but I'm happy to be with you now. I'm going to walk you through a quick case study of what came out as a routine sit call at a local gathering a couple years back. What we had essentially on the dispatch info was it was noon, about 85 degrees, clear, sunny, humid, hot, to a local athletic park, a little soccer event going on. We were called out for a sick patient, came out as 26 Bravo 8. First aid staff called it in for us. Dispatch info seemed to indicate there was a little bit of confusion and panic on the scene regarding what was going on, so law enforcement was all dispatched. So upon our arrival, showed up on scene with our law enforcement officers, and we were guided back to a female that looked pretty sick, slumped over a trash can underneath a canopy with some bystanders at her side. Just as an aside, we were in the food vendor area of the event. They advised that the patient seemed to be in a full sprint, was running toward them, looked like she was going to run past them, and then collapsed right in front of the tent. So went ahead and grabbed her and took her to shelter, get her out of the heat. Nobody knows her, of course. Nobody knows nothing in situations like this, but nobody knew this patient, which inhibited her assessment. General impression, however, was that she was 60-ish. She appeared to be very ill, altered mental status, and she looked to be pretty mottled as well. Kind of had some abnormal skin color, sort of like what you see in the bottom of the slide there. As far as her circulation was concerned, radial pulses were absent, and her carotids were weak and thready. Regarding her airway, no outward signs of angioedema, no swelling, no bleeding, no vomit, nothing we really needed to take care of at the moment to secure the patency. Her breathing, though, was a little bit shallow, a lot bit shallow rather, and did appear to be inadequate. So, first thing we need to do for this lady, as far as initial interventions were concerned, was take care of that blood pressure concern. We noted the absent radial pulses, and we decided to go ahead and take her supine to go ahead and get some blood where it needed to be. Decided to use gravity to help us out with that. Next thing we did was call for a code response. Dispatch some additional folks. We recognize what looks to be a peri-arrest situation, and we want as many hands on the scene with us as we can get before we think we need them. While that's going on concurrently, EMTB partners getting together the BVM with high flow O2 and just going with basic airway maneuvers to get this lady some air. While that's happening, the paramedic partners getting the IV equipment prepared. So we're history, right? We want to know what the lady's deal is, what's going on, how long she's been like this, etc. There's none available. Nobody knows her. The bystanders just sort of repeat the story for us rather. They were preparing food and noticed the patient in what looked like a full sprint coming from the opposite direction we had approached with an unsteady gait. They watched her deteriorate from a full sprint to a stumble to a crawl in front of their tent. So they decided to scoop her out and get her out of the sun. They didn't note anything that looked like seizure activity, and they said that the patient was trying to speak, but she was just moaning, incomprehensible, nothing they could really get a fix on. So they just went ahead and called for help. Regarding the physical exam, now that we've got the breathing being assisted, positive pressure ventilation, we need to try to figure out exactly what's going on. So we run a real quick physical exam on her to see what we can't grab. And like I mentioned with her skin, just take a glance at it there. It's something real similar to it. She was mottled. She was cyanotic. She was diaphoretic. Capillary refill was actually absent in her really pale fingers. They're those fingers that you just kind of pinch and they stay white, they stay blanched. That's what we were looking at. Essentially, she was very, very warm to the touch as far as her core was concerned, with very cool extremities. Pupils were midpoint. They were reactive. Popped her on the monitor just as quick as we could, and we found a sinus rhythm with no ectopy. did not get a 12 lead at this point in time, just because we had other things that were a little more pressing. But it's something we were going to circle back to here in the future. While that was going on, slapped on the non-invasive blood pressure cuff, and that timed out. We weren't able to get a blood pressure on that. We knew it was low. We were just hoping to kind of quantify that rather, just a little bit. And the pulse ox, kind of like I mentioned there in quotation marks, it's audible, and it's being very loud, obnoxious, and it's telling us less than 60% or less than 50%. We didn't particularly, we weren't surprised by that information, and I'm not sure we can really pay too terribly much attention to the quantitative value that we get off the pulse ox, being that she's not perfusing her fingers, but it did let us know what we suspected, and that her pulse ox was very poor from that point. In the past 60 seconds or so of getting this information, the EMT partner reports that he's watched, or she rather, has watched the heart rate drop from the 80s through the 70s to the 60s, and is currently declining at a rate of about 56. Partner also reports that the efficacy of the bagging is very, very difficult. It's tough to gauge. The patient's still kind of fighting around. She's anxious. She seems to be air hungry, and if only she would relax, it'd kind of make things a little bit easier as far as that's concerned. Well, anytime we hope for stuff like that, it tends to happen. The patient actually did relax. She got very, very calm, a little too calm. Just as the fire department, our QRV medic supervisor, was arriving on scene, the patient appears to have lost all muscle tone and carotid pulse. However, she maintained a very, very pretty rhythm with a rate of 38 on the monitor. The incoming units were advised that they had a working code that they were dealing with, or that they'd be responding to. Pads were applied, fire department took over CPR, EMTB partner readies and inserts an appropriately sized blind insertion airway device. It was a King, I want to say it was number 3. QRV medic there with you goes ahead and he readies and places an IO in the right tibia and starts with the cold fluid bolus and goes on with 1 milligram AbbVie. While all that's going on, your EMTB partner reports that the blind insertion airway device seems to be moving air just fine, has an end tidal value of 34, end tidal CO2 of 34, end tidal CO2 value. We need to actually kind of figure it out, so that kind of brings us to everybody's favorites, right? H's and T's, kind of a checklist as for what's going on. So we'll just run through them real quick here. The hypoxia, it's being addressed, right? We got high flow O2 running through the BVM with the blind insertion airway device. We seem to be getting chest rise. However, we are addressing the hypoxia issue right now. Hypo or hyperthermia, it certainly could be something to keep an eye on. The patient's presentation is telling us that it could be a heat-related emergency as well. We did not get a tympanic temperature, but we do have the cold saline running, just as we typically do for cardiac arrest, unless it's contraindicated in the area that I work. Hydrogen ion, always something to consider, being that the patient did appear to be hypopneic before she went down, and partner reports tight lung sounds. Could certainly be something to keep an eye on. Hypovolemia, that's being addressed. We do have patent IO running. Somebody's going to go ahead and get more access just as soon as they get around to it. But we're just focusing on the important stuff right now, the airway and the circulation. Hyperkalemia, always a possibility, but we don't really suspect it at present. We don't have any reason to believe that the patient's anything like an ESRD patient, etc. Those situations you'd expect your patient to be hyperkalemic in. Hypoglycemia, always something to keep an eye on, and everyone kind of crosses their fingers and hopes for a value of 20, but it came back at 74. So of those, all of the H's there that we talked about, we have 2 that we're really paying attention to right now, the hypoxia and the hydrogen ion. Both of them kind of go hand in hand, especially when you're worried about airway vacancy. So over onto the T side, tension pneumothorax, trachea did appear to be midline, neck veins are visible but don't appear to be grossly distended, As far as the tamponade is concerned, we're really not too concerned about it at present. We don't see any JVD or anything that really points us down that route. Thrombosis is always something we need to be considering, especially with cardiac arrests of unknown etiology. And we got to remember that our thrombi, I think is right, is kind of a double whammy. Pulmonary embolism or cardiac are always issues we need to consider there. Toxins. Her pupils are pearl, which tells us just a little bit. It can kind of rule out a couple of things for us. But when we talk about toxins, we always have to think about exposure as well. So it could certainly be something that she's been exposed to. So we're going to kind of narrow it down just for the sake of this here, and it's going to be we're worried about PEs and toxic exposure. So when we form our differential diagnosis, kind of what we're working with in the field, we need to not get tunnel vision on one thing over another. So the differential diagnoses for this patient are going to be a heat-related emergency versus pulmonary embolism versus toxic exposure. After the first dose of epinephrine and really great high-quality CPR, we got ROSC. Strong carotid pulse that correlated with the monitor, and tidal shot right up to 76. And as you can see kind of from the depiction here, the shark fin waveform was much more discernible. Certainly something that caught our eye right there. As soon as she started perfusing, the patient's skin color, it changed. Didn't really get better, it just changed. Looked like now that she was perfusing well, and we were actually getting blood to the skin surface, we were able to see that cyanotic modeling nastiness that we were looking at earlier kind of gave way to this splotchy color with hives and rashes becoming more apparent about the patient's chest, their neck, their abdomen. Now that we're perfusing more, we're starting to see these signs. Anaphylaxis, that toxic ingestion we were talking about, kind of creeps up higher and higher on our radar. That might explain why we get such a quick response from the epinephrine. With that newfound information, we went ahead and jumped down the common treatment bundle for anaphylaxis. That's going to include the salumedrol, the Benadryl, the H2 blocker if we've got it, Atrovent with continuous albuterol, nebulized through the PPV, through that blind insertion airway device. And we've already given the epi, which is the most important thing in our anaphylactic reactions. We gave that IV at the start of the code, which looks like probably helped things out. Fahrenheit, GCS is still holding right about 3. After we get codes back in this area, we sit on scene about 10 minutes just to make sure that nobody's going to re-arrest, etc. So while we're doing that, we're getting our secondary assessment and taking care of things that we might not have done in the earlier parts of the code. So secondary is going to show that those hives are starting to clear up. Her pupils are still pearl. Went ahead and ran a 12 lead while she was laying on the ground. No immediate life threats, right? No STEMI, nothing to activate the cath lab for, etc. No rate problems that we had to treat at present. There's been no improvement in the respiratory rate. However, 92% with high flow O2. End tidal CO2 is 60, and there's still some lingering signs of bronchospasm. Is there anything else we want to do to go ahead and treat that? We certainly could, but one of the things that we have to remember is the English proverb that the enemy of good is better. And you see that kind of written in a couple of different ways. There's some write it, better is the enemy of good. And essentially what that means is, you're just in cardiac arrest. Pulse ox was just less than 50%, and now we've got her up to 92, and we've got pulses back. It might be a good time to just sort of sit on your hands and see what's going to happen, as opposed to trying to chase these scant bronchospasms down with something like mag sulfate, which is going to have more effects on blood pressure, etc. So it was just about this time that family showed up. Husband kind of came wandering over looking for his wife, wondering what was going on, and it turned out I saw her at the restrooms. They had parted ways to go into the restrooms, and he wasn't able to find her, so he came back. He was a short, relatively thin male, appeared to be in decent health, but was noted to be wearing extensive hearing devices in both ears. He indicated that he was extremely hard of hearing, but was able to effectively read lips. He advised us that his wife, who was our patient, completely deaf. I said, patients in cardiac arrest, that's really okay, but what about those peri-arrest patients? Deafness and being hard of hearing can cause problems as far as that goes, as far as communicating. So from the husband, we were able to gain a sample history. Um, like I said, the signs and symptoms, right, it was reported by the bystanders. They gave us all of that information. The allergies are kind of interesting. She had anaphylactic reactions to peanuts and insect bites, but that's been a couple of years ago now. I said she has seasonal allergies as well. As far as medications, just Claritin. She is, however, prescribed an EpiPen, and that's in her vehicle's glove compartment. Probably no coincidence that that's the direction in which she was running. Um, as far as her medical history is concerned, she's been deaf since birth. Last meal was fried fish about 35 minutes ago now. EMS been on scene for about 25 as far as that's concerned. So definitely enough time for something nasty to have gotten into the system. So what happened? Um, a husband advised that they attended this soccer event about 10 a.m. this morning, went to the vendors area for lunch, and got some fried fish. A little while after having that, wife reported that her stomach was upset and that she needed the restroom, and he did too. So they kind of parted ways. He went to the men's room, she went to the women's room, and he came back out and didn't see her. Figured she was still in there, and after about 20-25 minutes, decided that he probably ought to walk back up to the soccer park and see if she made her way up there. And that's when he found her, in care of EMS. So why do we need to talk about this? What do we need to consider with deaf and hard of hearing patients? Epidemiologically speaking, we're going to see these patients often. Not particularly the deaf patients, but patients that do have communication problems, patients that aren't quite able to hear. So things we definitely need to be concerned with. According to a couple of studies that I found, about 15% of patients over 18 report some trouble hearing, just some. The number jumps to 25% when you look at patients between 65 and 74 years old, and when you get above 70, all patients, all comers, you're looking at about 50%. Men are typically more afflicted than women, and another study that I found indicated that all patients, all comers, as far as age are concerned, about 50% of men and 33% of women over the age of 65 are affected. So what about it? What can we do about deaf patients? And we need to just kind of think about communication tips, rather, whether a patient is deaf or just plain hard of hearing. A couple of things we need to be concerned with, a couple of things to sort of keep in mind when we're taking care of these folks. The first, and it's highlighted, highlit, whatever proper English is for that, in red, is not to assume that your patient's deaf due purely to their age. It can be offensive to some people to be yelling in their face when they can hear you just perfectly fine, so be careful of that. Ask the patient for their preference as far as communicating. Patients like to write, some like to sign, some like to use charts. Just be sure to ask if your patient is coherent enough. Always face the patient during communication. A lot of these folks have figured out how to read lips, and they can't do that if they're looking at the back of your head. Kind of tagging along with bullet point number 1 there is to not over enunciate. Again, this can be sort of insulting if you're going way over the top enunciating for folks that don't particularly need it. And then whenever you're dealing with folks that are trying to rely on written or on facial expressions or on reading lips, you have to make sure you're in adequate light to be able to do that. So how'd the patient do? Transport was largely non-eventful. She did, however, regain a spontaneous respiratory rate of 12. And about the time we got to the ED, she started coughing, gagging, became very tearful, very anxious, but she calmed down with a couple of 25 microgram aliquots of fentanyl. Really didn't want to hit her with Versed or any of the sedative hypnotics just because we didn't want to blunt her neuroassessment, which was already just a little bit hindered by the fact that she couldn't speak regardless of the tube in her throat. Upon turnover of care to the ED, she was able to communicate with her husband, who was able to in turn communicate to the ED staff via American Sign Language. Via signing, she was noted to be A&O times 4, and after noting her normalized vital signs and a decent ABG whose values I just can't remember, the decision was made to buy it. She did well. Shortly after that, she was able to explain in the ED before going up to the floor again via signing that she had severe cramping after the fish, thought she needed the restroom, went in, sat down at the stall, immediately breathing difficulties ensued, and she got up to try to go get her EpiPen. And that's about where she collapsed. She said she remembered making it about halfway there, which is about 100 yards. She was actually discharged the next day with a CPC category of 1. And just as a brief review for you, CPC category is just the cerebral performance category scale, and that's how we measure neurologic outcomes of cardiac arrest survivors. 1 to 5, 1 being good, 5 being the worst. 1 and 2s are what we want, which are acceptable. Anything less than 3, we kind of consider ourselves to have failed. So, in summary, maintain a wide index of suspicion for anaphylaxis with apparent hypotension, regardless of the obvious presence of hives. There's one study out there that I was able to find in Pediatrics, which is the American Academy of Pediatrics publication, that indicated skin symptoms may be absent. They're actually absent most of the time with kids and adults, or this study was primarily on children, but it talked about kids and the skin symptoms being absent, particularly with ingested agents, allergens that cause these anaphylactic reactions. So can't necessarily rely on the hives all the time. One of the take-home points that I took from this as well is when we're dealing with the hard of hearing or the deaf, we need to consider utilizing and transporting with someone capable of effectively communicating with our patient. It's at all feasible. Here he was riding up in the front seat. We didn't really need him until we got into the ED, but having him there definitely saved this patient from being medically induced into a coma and going up to the ICU. Here are your references. I appreciate all your time, and again, my apologies for the tardiness.